Are you ready to learn with fun? Brace yourselves for the ultimate test of knowledge in the Cardiac Super League. Witness the clash of giants as 12 formidable teams step into the arena, battling it out for cardiology supremacy. In this exciting collaboration between Wilson's Pharmaceuticals and the Pakistan Cardiac Society, the Cardiac Super League promises intense competition and groundbreaking learning experiences. Stay tuned as the teams showcase their expertise, strategic brilliance, and unwavering determination. Who will emerge as the true champions in cardiology? The main goal of the case-based learning approach is to equip students and healthcare professionals to refine their clinical practice by learning the latest advancements. The Cardiac Super League awaits you, guaranteeing to advance your education. Join us and become part of an incredible journey. Visit our Facebook page or contact us for more information.
Assalamu alaikum everyone, this is Hamza Hussain and welcome to Pakistan Cardiac Society's Cardiac Super League powered by Wilson's Pharmaceutical. Today we are live for the second semi-final match between two exceptional teams, P.I.M.S Leopard and A.F.I.C Lions, and they both will be competing with each other for securing a position in a grand finale of Cardiac Super League, which will be played against Jinnah Eagles. Allow me to introduce the senior faculty members available with us. We have with us the match umpire today, Professor Mohammad Ishaq. He's Professor of Cardiology at Karachi Institute of Heart Disease. And along with him, Chairperson of Cardiac Super League has also joined us, Professor Feroz Mehman. He's Professor of Cardiology and Vice Chancellor at the University of Modern Sciences, Dr. Mohammad Khan. And from the Governing Council of Cardiac Super League, we have with us Professor Khawar Abbas Kazmi. He's Professor of Preventive Cardiology at National Institute of Cardiovascular Diseases, Karachi. And another senior faculty member, Brigadier Abdul Hamid Siddiqui, has also joined us. And moderator of today's program is Dr. Ashraf Bilal. He will be moderating this second semi-final match. And I will request Dr. Ashraf Bilal to please start the proceeding of this second semi-final match. Over to Dr. Ashraf Bilal.
Thank you, Hamza. I would like to welcome both teams, the P.I.M.S Leopards and A.F.I.C Lions, for this second semi-final. I would also like to welcome Professor Khawar Kazmi, Professor Feroz Mehman, Brigadier Abdul Hamid Siddiqui Sahab, and last but not the least, Professor Ishaq Sahab. He will be today's umpire as well. And all three other members will be helping us out as a panel expert. So with this, Hamza, sorry, I have to keep this mic with all the time close to my mouth because I think the voice is not good. So Hamza, we should go with the coin toss first. So I would like A.F.I.C Lions to choose the head or tail, whatever they like. Okay, Hamza, can we proceed with the coin toss? Okay, just Hamza, are you getting me?
Yes, sir.
Okay, Hamza, sorry, just a minute. Okay, would you like me to explain the game scenario and the game procedure today as well before
Yes, sir,
we
please.
start the game? Okay, so for both teams, we will have a scenario-based 10 questions. We will ask with each team. If the game will tie, then we will ask another 2 questions with each team to sort it out with the same scenario. If still the game is tied or both teams have equal marks, then we will gonna ask another scenario with 10 questions each, but that will be on the sudden death basis. Means that we have to ask one question with each team one by one, and whoever is dropped the answer or give wrong answer, the game will be ended there and then. And again, I just would like to remind everybody that you have to answer or you have to choose your option within the given limit of time. That's very important. Okay, is both teams agree with this? Yes, A.F.I.C Lions and Prince Leopard. If you guys have any question, you can ask now. I cannot listen to anybody of the are they?
The mic is not working, I guess, from A.F.I.C Lions and.
I mean, you can hear me?
No,
We
we have
choose.
listened.
We
We have listened to you, and it's okay. There is no question from our side.
Okay, P.I.M.S leopards are okay with it. A.F.I.C lions, please. Are you guys okay with?
Yes, we are okay.
Okay, that's fair enough. So I just choose A.F.C lines for you. Just to we are gonna do the coin toss, so you can choose head or tail, whatever you like. A.F.I.C lines.
Heads is the call.
Okay, that's fine. Hamza, please do the coin toss. Okay, it's tails. So it's P.I.M.S leopards who won the toss. Okay, P.I.M.S leopards, it's up to you now to
We would
choose
like to
whether.
answer the questions first.
Okay, that's fair enough. You have already decided. So, Hamza, please put the questions from A.F.I.C line side. Yes. Okay. Yes, A.F.C
A, six,
lines. Just
a
continue,
60
please.
years old male, hypertensive, diabetic, smoker for the last 25 years, presented to OPD with history of an episode of loss of consciousness one day ago. He described this episode as sudden blackout while going to the washroom in morning. Nobody witnessed that episode. When he regained consciousness, he was on the floor with vomit on his clothes. He doesn't remember the events during the period. He said that he felt very tired after the episode. Presently, he is fine, no symptoms. He walked himself in the clinic. No previous history of any cardiac event. He is taking oral antidiabetics for diabetes, ARBs for hypertension, and alpha blockers for benign prostatic hypertrophy for the last 2 years. No previous history of such episode.
Okay. P.I.M.S leopards, are you happy with the scenario? Should we proceed? Yes, P.I.M.S leopards. P.I.M.S leopards, are you hearing me?
Yes.
Yes, we have read the scenario.
Okay,
Proceed.
that's fine. Hamza, please proceed with question number one.
Tired after the episode. Regarding syncope, which
Question number one is regarding syncope, which of the following is true? Option A: syncope or transient loss of consciousness is a symptom that presents with abrupt, transient, complete loss of consciousness, with or without loss of postural tone, and with rapid and spontaneous recovery. Option B: cessation of cerebral blood flow leads to loss of consciousness with approximately 20 seconds. Restoration of appropriate behavior and orientation after syncopal episode is usually immediate. Option C: up to 50% of young adults report a previous episode of loss of consciousness, mostly isolated events that never come to medical attention. Option D: the prevalence of a first episode of syncope is particularly high between ages 20 and 40, with additional peaks at approximately 60 and 80 years. Option E: syncope caused by orthostatic hypotension is associated with a twofold increase in mortality.
Okay, P.I.M.S leopards, your time starts now.
I'm really okay with option A and option B. Both of them seems fine. लेकिन 20 seconds की window का मुझे नहीं पता. I think इसमें एक चीज़ बस देख लें कि there is symptom present with abrupt. Abrupt भी होती है, transient भी होती है, complete loss of. नहीं, लेकिन it's a syncope, it's not a cardiac syncope. जो vasovagal है उसमें तो आपको prodrome होता है. Loss of postural tone and with rapid and spontaneous recovery. Cessation of cerebral blood flow leads to loss of consciousness.
Okay, 50 seconds left.
Restoration of appropriate behavior and orientation. C, D, E, तो out है. E, E, E में E तो नहीं है. नहीं नहीं. Immediate होता है.
Okay, almost 30 seconds left. P.I.M.S leopards for you.
20 seconds is too much.
ज़्यादा है?
हाँ, 20 seconds.
We should go with A. We would like to go with option A, syncope or transient loss of consciousness.
Okay, Hamza, please stop the timer and lock option A. Oh, sorry, wrong answer. No problem, no worries. It's just a first question. Okay, we'll move towards question number two. Yes, A.F.C Lines, please ask your second question.
Question number 2. House officer sitting next to you immediately jumped to a diagnosis of vasovagal syncope. Although it is the commonest cause of syncope, but you still doubt it. Regarding VVS, what is not true in the following options? Option A: associated with low systolic, higher diastolic blood pressure and higher heart rate.
Option B, there is reduced venous return and lower stroke volume as possible reflex triggers. In individuals with hypotensive susceptibility, syncope may occur if triggering. Option C, possible reasons for the hemodynamic features of VVS patients are lower circulating blood volume, a tendency to increased venous pooling, and abnormal neuroendocrine activation. Option D, anxiety might be a component of the reflex related phenotype. Option E, there is no role of genetics in VVS.
Not एंजाइटी तो है, ठीक है। पॉसिबल रीजन में जो अंडरलाइन पेन की abnormality है वो भी है, reduced venous return and lower stroke volume भी है। अच्छा, abdominal systolic, high diastolic and higher heart rates, diastolic ज़्यादा नहीं था, ये गलत है।
ये मेरा ख्याल गलत है।
हार्ट रेट का भी
वेसोवेगल में तो वो होती है ना, रेडिकार्डिया होता है।
हाँ
क्योंकि उसमें नहीं किया था वैसे नहीं रिस्पॉन्स
हाँ
ठीक है,
ए
एक दफ़ा देख लें दोबारा बाकी ऑप्शन।
बी तो ठीक है क्योंकि उसमें होता है पॉसिबल रिफ्लेक्स ट्रिगर्स होते हैं, न्यूरोएंडोक्राइन एक्टिवेशन भी होती है, फिनोटाइप्स।
Sorry, Hamza, I think my line was dropped, internet line. So,
ए
okay, it's 35 seconds left. Can you just...
Option A, associated with lower systolic, higher diastolic, and higher heart rate.
Okay, you still have 20 seconds. Is this your final answer?
Yes.
Okay, Hamza, please stop the timer and lock option A. Oh, wrong answer. Anyway, no problem. For the next questions,
Not a very good start, Asher.
Sir, are you hearing me?
Question number 3. You convinced your house officer not to jump at any diagnosis. Investigations are necessary to make a diagnosis. You ordered ECG along with other blood tests. ECG showed sinus rhythm with a few ventricular ectopics and QT interval of 482 milliseconds. Regarding long QT interval, which of the following is not true? Option A, 10 to 15% of long QT syndrome gene carriers have a normal corrected QT duration. Option B, ventricular arrhythmias usually occur in the childhood and early adulthood, or in case of female patients in postpartum and during menses. Option C, the pathogenetic basis involves alteration in ion flow with delayed after depolarizations and imbalance in the sympathetic tone. Option D, QT interval may be prolonged as a result of reduction of outward sodium current or increase of inner calcium current, interfering with the delayed outward rectifier potassium current. Option E, reduced sympathetic activity of the right stellate ganglion or an increased activity of the left stellate ganglion may lead to increased sympathetic tone of the heart and QT prolongation.
ठीक है, सीपी के पैथोजेनिक बेसिस जो है ना होती हैं डिलेड आफ्टर डिपोलराइजेशन और बेसिकली डिलेड रेक्टिफायर पोटेंशियल करंट की वजह से ही होता है ना, तो सोडियम कैल्शियम की साथ में
15% of the long QT gene cases have a normal corrected.
मुझे लगता है कि जीन से ज़्यादा बताना अच्छा है।
Ventricular arrhythmia can start earlier in case of.
Okay, Hamza, I am back. Sorry guys. Hamza, can you listen to me?
Postpartum type 2 होती है।
Hamza, please answer.
Yes, sir, we are listening to you.
Okay, sorry guys.
Interfering with the delayed output. Prolonged increasing of QT interval के बारे में क्या चीज़
Number 3, okay,
है?
what 39 seconds left. Sorry for inconvenience.
D or A? D or A?
10 seconds left.
Okay, 9 seconds.
Option
left.
A. Option A.
Okay,
10 to
Hamza,
15% of long QT.
Stop timer, Hamza, and lock option A, please. Okay. Sorry, since leopards up till now, but don't be disheartened. And we will move towards question number 4. Yes, AFC Lions,
Let's
please
move
ask
to
your
it.
next question. Just
Question number
relax,
4.
okay? Yes,
Question
please go
number
ahead.
4. Regarding the types of long QT syndrome, which of the following is not true? Option A, in congenital long QT syndrome, also known as catecholamine dependent VA, are typically triggered by an increased adrenergic activity. Option B, in the acquired form, also defined pause dependent, long QT syndrome is induced by a bradycardia or a sequence of interchanged long short RR interval. Option C, in congenital type, autosomal recessive is Romano-Ward syndrome and autosomal dominant is Jawai-Lang-Nielsen syndrome. Option D, the presence of a confirmed pathogenetic mutation in congenital type is diagnostic criteria for long QT syndrome irrespective of QTC duration. Option E, long QT1 patients usually suffer cardiac events during physical exercise, long QT2 during emotional stress or exposure to loud noise, that is alarm clock or phone ring, and long QT3 during night sleep.
What do you think? मेरा ख्याल है कि you don't need the mutation का आपको वो नहीं है information जरूरी तो नहीं है उसको able करने के लिए
The voice is
the presence of a
disrupted.
confirmed pathogenic mutation. Huh?
Okay, your time starts now.
Romano-Ward और age में नहीं एक इनमें डोमिनेंट है और मुझे ये नहीं याद कि कौन सा है
समझ नहीं आ रहा मेरा टाइमर
एक के साथ वो hearing abnormality associated होती है Romano-Ward के साथ होती है मेरा ख्याल है कि क्यों खलील भाई यूजुअली सफर गाड़ी में ये तो ठीक है
मेरे मोबाइल से लगा दो इसको
ये ठीक है
Ashar, your sound is still not good.
The bradycardia sequence of interchange long RR interval in congenital known as catecholamine dependent is a typical
20 seconds to go.
Hamza, can you hear me? So now 15 seconds left. Guys, can you hear me?
नहीं डी ठीक है आप कह रहे हो
10 seconds to go.
बताएं ऑप्शन सी फॉर कैट
Okay, right answer. Hamza, I'm back. Can you listen to me?
Yes, sir, we can listen to you.
Yes, guys, I'm really sorry. I mean, I think everybody is getting disturbed with because of internet problem with me.
चले अकाउंट तो खुला कुछ
That's very good. Congratulations, P.I.M.S Leopards, for your first 6 runs. Okay, with this we will move towards next question. Next question, please. Question number 5.
Question number 5. Although QT interval is prolonged in ECG, but you want to exclude other causes of syncope as well. Which of the following is having the least likely possibility of syncope when investigated? Option A, cardiac etiology. Option B, reflex syncope in. Option C, orthostatic hypotension. Option D, psychogenic pseudosyncope. Option E, unexplained.
Okay, your time starts now, P.I.M.S Leopards.
Normally नहीं कहे कि अगर आप generally investigate
Which of the following is having the least likely possibility of syncope when investigated? नहीं
इसमें नहीं बताना generally बताना generally बताना
जनरली syncope की सबसे लिस्ट वो वर्कअप में क्या आती है
orthostatic तो पता चल
कार्डियक एटियोलॉजी भी रिफ्लेक्स syncope साइकोजेनिक सूडो syncope मेरा ख्याल है इसका पॉसिबिलिटी कम होती है नहीं इस this question is particularly targeted for this scenario or it is generally asking
Because well, your time is running now. You have to answer and then we will deal with your query.
which one of the following is having the least likely possibility of syncope
30 seconds left.
तो वो
P.I.M.S
ये
Leopards for
पूछना है
you.
कि syncope की सबसे लेस कॉमन कौन सी है कार्डियक एटियोलॉजी रिफ्लेक्स भी कॉमन है ऑर्थोस्टैटिक भी कॉमन है अनएक्सप्लेन्ड और साइकोजेनिक में देख लें
Okay, last 15 seconds left for you, P.I.M.S Leopards.
Unexplained वैसे cause आपको नहीं भी मिलती most of the
9
time.
seconds left. Pimps left for you.
We would go with option D, psychogenic
Okay,
pseudosyncope.
stop timer, please. Stop timer, Hamza, and lock option D. Right answer. Congratulations. Okay, with your question.
Well done, Pims. Well done.
Yeah, with your
Keep
question,
it up.
Pimps Leopards is actually is related to the scenario because they're asking about the syncope. So this is all about questions all about syncope around syncope.
No, we wanted to ask if whether they are asking about the possibility of syncope in this particular patient or generally the incidence of
No, I
different
think
types of.
it was a journal question, you know, because
Yes.
you can see with the patient. Okay, with this,
नहीं इसमें
with
general
all permission of the panel, we'll move towards the next question. Yes, AFC lines, you can ask your next questions, please.
Question number 6. From clinical perspective, your suspicion was high for situational syncope. In addition to other tests, you plan to get a tilt table test also. Regarding tilt table testing, all of the following are true except option A. Tilt table test allows for investigation of hypotensive but not bradycardic phenotype of vasovagal syncope. Option B. The Italian protocol is probably the most widely used. Option C, continuous ECG and beat to beat BP monitoring is optimal for recording hemodynamic information. Option D, the test should be continued until complete loss of consciousness occurs or the protocol is completed in order to detect full vagal effect in case of unexplained syncope. Option E, it is the investigation of autonomic pathway, not cardiac pathway of vasovagal syncope.
Okay, your time starts now.
D के बारे में क्या ख्याल है? You want the patient to be out of consciousness completely?
Unexplained है तो फिर तो
I will go
full
with
लिख
option
तो अपने full करना है.
अच्छा. Continuous ECG, Italian protocol. I don't have any idea. EP वाले कितने थे?
option है.
ब्रेडिकार्डिया भी अगर होगा तो वो तो डिटेक्ट करेगा ना.
दोनों से आती हैं. ब्रेडिकार्डिया ही होते हैं उसके बाद वो
नहीं वो होता क्या है वो नहीं पूछ रहे हैं. मतलब वो ये पूछ रहे हैं कि दो etiologies हैं या तो पेशेंट हाइपोटेंसिव हो रहा है या ब्रेडिकार्डिक हो रहा है.
Okay, 50 seconds left for you, Pimps
ब्रेडिकार्डिक
Leopards.
as well.
yes
हाँ
yes तो इसी जनरेटर लगा होता है.
तो all of the following are true except.
एक्सेप्ट तो वही है ना.
नहीं,
ब्रेडिकार्डिया नहीं देख सकते.
अच्छा.
दूसरा जो दी है उसमें तो क्या unexplained clinical
30 seconds left, Pimps Leopards, for you.
ऑप्शन डी.
You have to make the patient unconscious. मतलब उसमें आपने करना है या अगर आपको नजर आ रहे हैं तो you will stop the investigation.
ऑप्शन डी ठीक.
Option
Okay, last 15 seconds left for you.
Option
Pimps
A.
Leopards.
A for alpha.
Oh, okay. Hamza, please stop timer and lock option A. Right answer. Congratulations. Okay, now you guys start playing very well. Okay, with this we will move towards question number 7. Yes, A.F.I.C.
देखेंगे ना गैप.
lines.
चलो अभी आगे भी जा रहे हैं फिर.
Okay.
In addition to
Question number 7. In addition to tilt table, 25 hour ambulatory BP pressure monitoring is also a test for determining the hypotensive cause of syncope. Hypotensive criteria for syncope includes which of the following options? Option A, males 24-hour systolic blood pressure less than 110 millimeters of mercury, daytime systolic blood pressure less than 105 millimeters of mercury, nighttime systolic blood pressure less than 95 millimeters of mercury. Female 24 hours systolic blood pressure less than 100 millimeters of mercury, daytime systolic blood pressure less than 105 millimeters of mercury, nighttime systolic blood pressure less than 90 millimeters of mercury. Option B, males 24 hours systolic blood pressure less than 105 millimeters of mercury, daytime systolic blood pressure less than 110 millimeters of mercury, nighttime systolic blood pressure less than 100 millimeters of mercury. Females 24 hours systolic blood pressure less than 100 millimeters of mercury, daytime systolic blood pressure less than 105 millimeters of mercury, nighttime systolic blood pressure less than 100 millimeters of mercury. Option C, males 24 hours systolic blood pressure less than 105 millimeters of mercury, daytime systolic blood pressure less than 115 millimeters of mercury, nighttime systolic blood pressure less than 97 millimeters of mercury. Females 24 hours systolic blood pressure less than 98 millimeters of mercury, daytime systolic blood pressure less than 105 millimeters of mercury, nighttime systolic blood pressure less than 92 millimeters of mercury. Option D, males 24 hours systolic blood pressure less than 100 millimeters of mercury, Daytime systolic blood pressure less than 95 millimeters of mercury. Nighttime systolic blood pressure less than 90 millimeters of mercury. Females, 24 hours systolic blood pressure less than 95 millimeters of mercury. Daytime systolic blood pressure less than 100 millimeters of mercury. Nighttime systolic blood pressure less than 85 millimeters of mercury. Option E, males, 24 hours systolic blood pressure less than 100 millimeters of mercury. Daytime systolic blood pressure less than 112 millimeters of mercury. Nighttime systolic blood pressure less than 90 millimeters of mercury. Females, 24 hours systolic blood pressure less than 97 millimeters of mercury. Daytime systolic blood pressure less than 103 millimeters of mercury. Nighttime systolic blood pressure less than 85 millimeters of mercury.
I hope, P.I.M.S leopards, you can understand this.
Hypertension.
Your time starts now.
I would think
देखिए हमने ये देखना है ना कि जैसे 90 के किस रीडिंग्स CSS बॉक्स में आ रहा है वो है E
Yes, Hamza, P.I.M.S leopards are with us.
तो ये
Yes.
पॉइंट
Okay.
ये पॉइंट ये रेज कर रहा है कि जो डी में है ना उसमें फीमेल्स में ज़्यादा लिखा हुआ है डे टाइम ब्लड प्रेशर डे टाइम का फीमेल्स में 90-60 यूजुअली होता है ना
वाला मेरे
नहीं,
सी
females का,
भी कंसीडर किया जा सकता है सी इसलिए क्योंकि ना इसमें 85%
क्या
85 पे तो हम
Okay, leopards, 50 seconds left.
85 पे कर रहा है 85 की रीडिंग तो नहीं है
85 वाले
सी में
सी नहीं डी
हाँ।
सी में देखें फिर तो ये सारे में से कोई भी उसमें नहीं
हाँ
sharp
नहीं
range
आ
में
रहा तो मैं डी और ई कह रहा हूँ ना
नहीं, मुझे ना उसका समझ नहीं आ रही कि systolic
हमने ये डिसाइड करना है कि इनमें से कौन सा क्राइटेरिया अप्लाई होता है तो
Okay,
हाइपरटेंसिव
30 seconds left. P.I.M.S leopards for you.
सी में तो सारे 90 से बढ़ के है ना
बट नॉर्मल
hypotensive बताना ना।
हाइपरटेंसिव
Okay, 20 seconds left, guys.
आई थिंक सी ये चूज करो
जल्दी बताओ।
डी
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 ये ना करें एक
10 seconds left, guys. 8.
ऑप्शन ई फॉर
Okay, stop timer, Hamza. Stop timer and lock option E. Oh, wrong answer. Okay, no problem. Better luck next time. Okay, with this, we will move towards question number 8. Yes, please, Hamza.
कंसीडरिंग सी
नीचे जा रहे हैं ना 90 से नॉर्मल ही नहीं रहता ना
Okay,
Question
guys.
number
8. Yes, please.
Question number 8. While you were planning to have further tests, suddenly patient added that sometime he had problem of dizziness after eating meals also. Criteria of postprandial hypotension is option A, 24 hours ambulatory blood pressure monitor, systolic blood pressure fall greater than 10 millimeters of mercury within 60 minutes of eating meals compared with the mean of the last 3 BP measurements before the meal. Option B, 24-hour ABPM systolic fall greater than 15 millimeters of mercury within 60 minutes of eating meals compared with the mean of the last 3 blood pressure measurements before the meal. Option C, 24-hour ABPM systolic blood pressure fall greater than 15 millimeters of mercury within 75 minutes of eating meals compared with the mean of the last 3 blood pressure measurements before the meal. Option D, 24 hours ABPM systolic blood pressure fall greater than 20 millimeters of mercury within 60 minutes of eating meals compared with the mean of the last 3 BP measurements before the meal. Option E, 24-hour ABPM systolic blood pressure fall greater than 20 millimeters of mercury within 75 minutes of eating meals compared within the mean of the last 3 BP measurements before the meal.
Okay, your time starts now.
सी और ई में
मैंने कहा
वन और डिप्लॉयमेंट्स के कितने ऑब्जर्वेशन चांसेस ज़्यादा ठीक है ये वो लोअर उसमें स्मॉल इंटेस्टाइन ये वो तो ज़्यादा चांस है उसमें वो बढ़ना शुरू हुआ राइट ये है कि 20 और 15 में से कितना रख सकते हैं आप
I think 20
उसमें
yeah, this is
ठीक है
not related particularly to that patient
ये डायग्नोसिस पूछ रही है कि अपना क्राइटेरिया क्या
postprandial hypertension का criteria
क्राइटेरिया फॉलो करना है इसमें तो
नहीं that makes sense कि पता है जब आपका जो gastric transit time है वो
Okay, 50 seconds left.
that means 75 minutes ठीक है
ये सी और ई में से आप क्या हम लें मैं 20 का तो फॉल होना चाहिए बड़ी 20 का
greater than 20 within लेकिन 75 minutes compared with the mean of the last 3
P.I.M.S leopards, 30 seconds left.
option E
कहते हैं यार मैं सब फाइन
option E for elephant
Okay, Hamza, please stop the timer and lock option E. अब दोबारा वॉइस कर रही मेरे कान में भी बोला
इट्स ओके फाइन ऐसे CP
अच्छा नहीं, मैं ना उसको ये रेटिंग्स देख रहा था कि 19 से नीचे कौन से हैं ये।
Okay, so right answer. Congratulations. With this, we will move towards question number 9.
I missed the point कि 90 से नीचे तो वैसे ही वो फिर
oh शॉक में
Yes,
नहीं
A.F.I.C lines, please.
we'll discuss it.
Question number 9. Patient had tilt-table test which came out to be positive and he was diagnosed as having reflex syncope or vasovagal syncope. Which of the following is true for diagnosis of vasovagal syncope? Option A, pattern of vasodepressor vasovagal syncope with hypotension only. B, pattern of mixed of vasodepressor vasovagal syncope with hypotension and bradycardia with asystolic pause greater than 2 seconds. Option C, typical hemodynamic pattern of mixed or vasodepressor vasovagal syncope with hypotension and bradycardia with asystolic pause greater than 3 seconds. Option D, pattern of mixed or vasodepressor vasovagal syncope with hypotension and bradycardia but without asystolic pause greater than 3 seconds. Option E, none of the above.
Okay, your time starts now. P.I.M.S levels.
पॉज की तरफ तो जाएंगे नहीं ना उसमें। हाँ तो vasovagal syncope में तो we don't need a ECG criteria for the pauses, right? Vasovagal syncope में
Without a systolic pause of more than 3 अगर
हाँ more than 3 तो वो तो pathological sinus node dysfunction नहीं हो जाएगा more than 3 seconds में। Typical hemodynamic pattern of mixed vasodepressor syncope with hypertension and bradycardia.
Okay, P.I.M.S levels. 50 seconds left.
I would go with without asystolic pauses अगर आपके more than 3 seconds आ रहे हैं फिर तो आपको sinus node dysfunction का मसला है। वो vasovagal तो नहीं हो रहा।
option D
वो तो sinus node का dysfunction है।
option D seems
Option D ना
seems fine but उसमें हमने bradycardia बीच वाले क्वेश्चन किया है।
Okay, 30 seconds left for you, P.I.M.S levels.
जो मिक्स्ड है ना वो टेंशन एंड वो तो ठीक है और जो वेजो
20 seconds left for you, P.I.M.S levels. Final 15 seconds left.
Khalil, I would go with D. D. बताएं।
Last 8 seconds left, P.I.M.S levels.
Option D. D for dog.
Okay, stop timer, Hamza, and drop option D. Right answer, congratulations. Okay. Okay, with this, we will move towards our final question for this inning. Yes, A.F.I.C lines, please ask question number 10.
Question number 10. Patient is advised physical counter pressure maneuvers as treatment of vasovagal syncope. All of the following are included in physical counter pressure maneuvers except option A. Physical counter pressure maneuvers are movements that promote cardiovascular stability and boost blood pressure through the exploitation of the skeletal muscle pump, often accompanied by increase in sympathetic drive. Option B, leg crossing. Option C, hand grip. Option D, arm tensing. Option E, the maneuvers are risk-free, effective, low cost, and first line treatment in patients presenting vasovagal syncope and can be advised as self therapy at home.
Okay, your time starts now, P.I.M.S levels.
Sympathetic drive increase होती है। Leg crossing से आप after load कम कर रहे हैं और जो आपका venous return भी बढ़ा रहा है।
hand grip से resistance बढ़ती है hand grip से resistance बढ़ती है
और आर्म
TPR
टेंसिंग से
arm tensing से क्या
वही होता है।
से वो
वही होता है।
hand grip से
मुझे ये बताएं
बढ़ती
कि
है
sympathetic drive increase होगी या नहीं?
leg crossing से भी दोनों बढ़ते हैं
नहीं इन maneuvers से होती है या नहीं?
50 seconds left.
Cardiovascular stability and boost blood pressure through exploitation of skeletal muscle pump, often accompanied by increase in sympathetic drive. What about A and E?
leg crossing
Like crossing से भी head grip से भी और arm tensing इन तीनों से हो रहे हैं।
30 seconds left, P.I.M.S levels.
Arm tensing से after load बढ़ता है, hand grip से भी after load बढ़ता है, leg crossing से आपके skeletal muscle preload बढ़ता है।
ठीक है
Last 20 seconds left for you, P.I.M.S levels.
यार आर्म टेंसिंग मैंने कभी नहीं पढ़ा आर्म टेंसिंग आइसोमेट्रिक है
Okay, 10 seconds left for you, P.I.M.S levels.
Option D. D for dog.
Okay, stop timer on the page and lock option D. Okay, wrong answer. Oh, sorry guys. Okay, so with this we will wind up the first inning, and P.I.M.S Leopard scored 30 runs. Just Hamza, I would like to give a little breath for both teams, and I would like to move towards Professor Firoz Mehman to ask his valuable comments for the game. Yes, Professor Firoz Mehman, if you can. Are you with us, Professor Firoz Mehman? I think Hamza, he is not with us, so I would like to move towards Professor Hawar Abbas Kazmi sir. Just please give us your valuable comments, please.
Uh, Good. I think whole exercise has been very special. I think it's a nice addition, nice learning, not just for the trainees. I mean, for us also. And we wish very best for both the teams. And if A.F.I.C is going to be now, I mean, challenging P.I.M.S, let's see. So best wishes and best wishes to Wilson also. Thank you.
Thank you very much, Professor Saab. And with this, I would like to move towards Brigadier Abdulhamid Siddiqui Saab. Just give us your valuable comments, sir.
I think again, Assalamu alaikum everybody, and very good practical scenario, but some of the questions require really scratching head and memory center, required memorization of the figures. But anyway, this is part of the question and answer session. It's good, good to be good at it because these are common question, common patient that we come across in everyday practice in cardiology. So, look up for the both teams.
Thank you very much, Professor Brigadier Abdulhamid Siddiqui Saab. I think both teams have a little breather now. Yes, guys, are you ready for the second round? Yes, P.I.M.S Leopards and A.F.I.C Lions. Guys, are you okay? Should we proceed?
Yes.
Yes, sure.
Okay, Hamza. So, yes, this is the scenario for A.F.I.C Lions. Yes, please proceed.
59 years old male presented in OPD with complaints of shortness of breath for last 2 years. He's diabetic and has a good control of diabetes. He's overweight with BMI of 27. He has extensive workup for his complaint, but he did not get any relief. Doctors advised him to lose weight because there is no obvious abnormalities in his test. He thinks his heart is not okay, but every time he gets echocardiography, doctor told him that his heart has 60% functioning.
Okay, so are you happy with the scenario? Should we proceed?
Yes, please.
Okay, yes, please.
What is true regarding heart failure with preserved ejection fraction? Patients with heart failure and mild or no reduction in the left ventricular ejection fraction has better outcomes than the patients with the severe systolic dysfunction. Heart failure with preserved ejection fraction is defined as heart failure in patients with the left ventricular ejection fraction greater than 40. Conventional and heart failure therapies have generally been effective at reducing cardiovascular death beyond left ventricular ejection fraction 40 to 50% or heart failure hospitalization beyond 55 to 60%. Option D, natriuretic peptide levels may not always guide diagnosis as they tend to be lower in HFpEF than HFrEF, likely due to lower diastolic wall stress and higher prevalence of obesity. Option E, E to E prime during exercise and at rest has shown to correlate reasonably well with the invasively measured pulmonary capillary wedge pressure.
Okay, F.I.C lines, your time starts now.
एक एक करके देखें. Option A तो obviously wrong है. ठीक है. They have similar outcomes. Option B में HFrEF की definition बन रही है, भी गलत है. Option C के conventional HF therapies have generally been effective at reducing cardiovascular death. Natriuretic peptide levels may not always guide diagnosis. They tend to be lower in HFpEF. Obesity की वजह से वो lower होते हैं. Likely due to lower diastolic wall stress and higher prevalence of obesity वाली बात तो ठीक है. ये low diastolic wall stress, हाँ ठीक है. नहीं, higher diastolic wall stress नहीं होगा इसमें तो. Diastolic, हाँ.
Okay, 46 seconds left.
डायस्टोलिक वॉल स्ट्रेस ज़्यादा होता है. Option. During study and that rest has been shown to correlate reasonably well with investigative.
30 seconds left. A.F.I.C lines.
Conversion therapies.
20 seconds left. A.F.I.C lines.
उसकी बात गलत है. T को देख लेंगे बात.
Last 12 seconds left for you.
We are going with option E.
Option E.
Yes.
Oh, yes, Hamza, stop the timer and lock option E. Okay, wrong answer. No problem, no worries. It is just a first question. Okay, so P.I.M.S leopards will move towards second question.
Question number 2. What will be the findings of tracings of LV pressure volume loops in this patient if he is suffering from heart failure with preserved ejection fraction? End diastolic volume, option A is end diastolic volume and end systolic volume are increased, leading to increased stroke volume without increase in left ventricular end diastolic pressure. Option B, reduced diastolic reserve blunts the increase in stroke volume and increases the left ventricular end diastolic pressure. Option C, end diastolic pressure volume relationship is shifted upwards and to the left due to the stiffer ventricle, leading to increased LVEDP even at rest. Option D, end diastolic pressure volume relationship is shifted downwards and to the left due to a stiffer ventricle, leading to increased LVEDP even at rest. Option E, end diastolic pressure volume relationship is shifted upwards and to the right due to the stiffer ventricle, leading to increased LVEDP even at rest.
Okay, your time starts now. A.F.I.C lines.
अच्छा, इसमें मेरे ख्याल से either to shift. Use diastolic reserve blunts and increase stroke volume. C या D में समझ लग रहा है. C has
50 seconds left. A.F.I.C lines.
हाँ.
30 seconds left. A.F.I.C
मेरे
lines.
ख्याल से C है. मुझे C लग रहा है.
20 seconds left for you. A.F.I.C lines. Hello, 15 seconds left.
मुझे C लग रहा है.
9 seconds left. A.F.I.C lines.
We are going with option C.
Okay, stop timer, Hamza, and lock option C.
Yes.
Right answer. Congratulations. Okay, so you have opened your account. With this, we will move towards question number 3. Yes, Hamza.
Mic on kar dein. Question number 3. Although most of the guidelines recommend diagnostic criteria for heart failure with preserved ejection fraction, but there are certain limitations to it. There are two heart failure with preserved ejection fraction diagnostic algorithms, the H2FPEF score and the European Society of Cardiology HFA-PEFF algorithm. All of the following parameters are included in H2FPEF scoring except option A, obesity defined as a BMI greater than 30, B, hypertension, C, atrial fibrillation, D, pulmonary hypertension, and E, elder age more than 65 years.
Okay, time starts now for you. A.F.I.C lines.
Hypertension भी मेरी hypertension के कारण
मैं A पे हाँ मेरे ख्याल से. हाँ? जो H2 टेस्ट है उसमें तो है. हाँ,
Okay, 50 seconds left for you.
H2 FPF है, HF है, अच्छा H2 हाँ
इसमें एक है
पल्मोनरी हाँ पल्मोनरी हाइपरटेंशन बेसिक तो है।
Okay, F.I.C lines, 30 seconds left.
मुझे लगता है इसका एट्रियल फिब्रिलेशन एक इसका वो डिपेंडेंट नहीं वो इंडिपेंडेंट एक है।
Last 15 seconds left for you.
Elder
9 seconds left for you, F.I.C lines.
option
seconds.
E.
Okay, Hamza, stop timer and lock option E.
Option E हाँ
Okay, right answer. Congratulations. Okay, good work, F.I.C lines. With this, P.I.M.S leopards, please ask your question number 4.
Question number 4. ECG showed atrial fibrillation and echocardiography revealed biventricular preserved LV systolic function, and E to E prime is more than 18 with restrictive filling patterns of mitral inflow velocity. PASP is 52 millimeter of mercury. What will be the likelihood of heart failure with preserved ejection fraction in this patient now according to H2FPEF criteria? Option A, low likelihood. B, intermediate likelihood. C, between low and intermediate. D, high likelihood. E, between intermediate and high likelihood. I would request the A.F.I.C team to please clarify the option while they are answering.
Okay, your time starts now.
AFib नहीं उस सिनेरियो में AFib तो नहीं थी पेशेंट को AFib तो नहीं सिनेरियो में AFib नहीं थी हाँ हाँ एज कितनी 60 थी पेशेंट की कैन वी सी द सिनेरियो
Yes, Hamza, please show them the
I
scenario
just want to
again.
have a quick look there to see
Yeah, no
what
problem. Yes, Hamza. Continue the timer and show the scenario.
diabetic है पेशेंट overweight है 60
Okay.
हाँ ठीक है you can
35
switch back
seconds left. Okay, that's fine. Hamza, continue.
so age कम है हाँ
Hamza, show us this timer, please. Okay, 25 seconds left for you guys.
हाँ
Uh,
2 to 6 के में है तो intermediate high like
15 seconds left.
intermediate and हाँ मेरे ख्याल से 2 to 6 के में बन रहा है ना
8 seconds left for you guys. 6 seconds.
option E
Okay, stop the timer. Hamza, stop timer and lock option E. Wrong answer. Sorry, guys. Okay, no problem. Better luck next time with this. P.I.M.S leopards, please move towards question number 5. Yes, go ahead, please. P.I.M.S leopards.
5. He has intermediate probability according to score. All of the following non-cardiac factors are involved in the pathophysiology of heart failure with preserved ejection fraction except option A, pulmonary diseases, option B, obesity, option C, skeletal muscle disorder, option D, anemia, and option E, all of the above.
Okay, your time starts now.
the following are non-cardiac factors involved in pathophysiology है pulmonary disease तो है obesity भी है skeletal muscle disorders में anemia all of the following are involved except है anemia तो फिर C बनता है इसका
Okay, 50 seconds left. The F.I.C lines.
हाँ skeletal muscle disorders तो skeletal muscle disorders वो आपकी pulmonary वो breathing वगैरह को
30
impair
seconds
करके
left. The F.I.C lines.
हाँ हाँ
20 seconds left. A.F.I.C lines.
हाँ हाँ मैं जाऊँ उसी से we will choose option C.
Okay,
Cat.
हम लोग को stop timer and lock option C.
ठीक था.
Wrong answer. Okay, guys. Better luck next time. With this, we'll move towards next question. Yes, P.I.M.S. Leopards, please ask your next question.
Question number 6. Your junior colleague is very interested in cardiomyocyte dysfunction in this entity of heart failure, which contributes significantly in the symptomatology of these patients. Which one of the following statement is not true regarding cardiomyocyte in heart failure with preserved ejection fraction? Option A, abnormal calcium hemostasis, which leads to increase in diastolic calcium or decrease in the rate of calcium reuptake, which leads to incomplete or impaired relaxation. Option B, increased ATP or decreased ADP, slows actin-myosin cross-bridge release. Option C, dysfunction in protein regulation for cross-bridge formation and calcium sensitivity. Option D, increased density of microtubules, which causes increased diastolic stiffness. Option E, there are titan isoforms, which leads to increased non-compliant isoform and phosphorylation state.
Okay, A.F.I.C lines, your time starts now.
This leads to increase in diastolic calcium. That's why the reason the calcium uptake leads to incomplete or impaired relaxation. Increase ATP or decrease, ADP slow, actin-myosin cross-bridge release. Dysfunction in protein regulation for formation of calcium sensitivity. Density of microtubules which causes increased diastolic stiffness. Microtubules for contractility. Microtubules for नहीं बस there is titan molecule.
50 seconds left. A.F.I.C lines.
Titan isoforms which lead to increased non-compliant isoform. Normal calcium increased.
30 seconds left for you, A.F.I.C lines.
हाँ ये not true है ना
20 seconds left.
हाँ हाँ हाँ
Okay, last 10 seconds left for you, A.F.I.C lines.
We're going with
10
option
seconds.
alpha. Option A, alpha.
Okay, हम लोग ले stop timer and drop option A. Oh, wrong answer. No problem. Guys, you still have chance. Better luck next time. Okay, P.I.M.S Leopards, you can ask your next question, please.
Question number 7. You are teaching your junior colleague that this disease is basically a problem in the LV relaxation. All of following are true regarding LV relaxation properties except option A. LV relaxation is an active energy dependent process. Option B, it begins with decay of force generating capacity, follows the completion of the ejection phase of the systole and continues through isovolumic pressure decline and the rapid filling phase. Option C, LV filling depends both on active relaxation and on the recoil suction that results from the release of the potential energy stored during systole by contraction. Option D, catecholamine-induced enhancement of relaxation and recoil during exercise increases the LV pressures in early diastole, thereby decreasing the LA to LV pressure gradient without increasing LA pressures. Option E, in patients with the heart failure with preserved ejection fraction, relaxation and recoil are abnormal at rest and not enhanced during increased heart rate or exercise. As a result, filling can be maintained only by increased LA pressure. Blood must be pushed into the left ventricle.
Time starts now, A.F.I.C lines.
Relaxation requires normal rest, not enhancement. The filling can be maintained only by enhancement of relaxation. With the decay of force and capacity.
50 seconds left for you, A.F.I.C lines.
begins with the decay of force generating capacity, follows the completion of the rejection phase of systole, and continues through isovolumic pressure decline. B ठीक है. LV filling pressures.
30 seconds left.
अर्ली डायस्ली में तो आपका पैसिव होता है, उसमें कैटेगरी ये डी की बात कर रहा हूँ.
Okay, last 15 seconds remaining for you.
तो पैसिव होगा.
10 seconds.
Option D, delta.
Okay, stop timer, Hamza, please, and lock option D.
No.
Right answer. Congratulations. Congratulations, F.I.C. Lions. With this, P.I.M.S Leopards, please ask question number 8.
Question number 8. For additional evidence, you asked pro-BNP and anti-pro-BNP, which level is supportive in this patient in favor of heart failure with preserved ejection fraction? Option A, anti-pro-BNP greater than 220 picogram per ml, BNP greater than 80 picogram per ml. Option B, anti-pro-BNP greater than 400 picogram per ml, BNP greater than 120 picogram per ml. Option C, anti-pro-BNP greater than 500 picogram per ml and BNP greater than 150 picogram per ml. Option D, anti-pro-BNP greater than 700 picogram per ml and BNP greater than 200 picogram per ml. Option E, anti-pro-BNP greater than 900 picogram per ml and BNP greater than 300 picogram per ml.
A.F.I.C.
इसमें जो है ना जो टोपोल था इसमें फर्क था, लेकिन टोपोल में जो था ना वो मिनिमम बीएनपी जो लिखा हुआ था वो 220 था और जो प्रो बीएनपी था वो 200 से ज़्यादा था. इसमें 220 की कोई रेट नहीं, सारे 300 वाला जो लास्ट की आ है और प्रो बीएनपी तो वैसे 900 से ज़्यादा. तो मेरा
वो HFrEF की बात तो नहीं कर रही आप?
नहीं मैं प्रिजर्व की बात कर रही. प्रिजर्व में 220 और 200 ये दो दिए हुए थे, ठीक है. एंटी बीएनपी मिनिमम 125 और 220 वो गाइडलाइंस
47 seconds left for you.
इसमें तो
क्योंकि मैंने मम्मी
किसी भी
seconds left for you.
तो प्रो बीएनपी की बात होती तो गलत है, एमबीएनपी की बात है. की पे कर लें.
Last 18 seconds remaining for you. F.I.C. Lions. Last 10 seconds.
ठीक है.
5 seconds left for you.
Option E.
Okay, stop timer, Hamza, please, and lock option E. Right answer. Congratulations. Very good. Very well done, F.I.C. Lions. You are still in the game, and with this, we will move towards our second last question of this inning. Yes, P.I.M.S Leopards, please ask question number 9.
Question number 9. All of the following are abnormalities of the hemodynamic of LV in heart failure with preserved ejection fraction except increased LV filling pressure. Option B, decreased diastolic reserve. Option C, increased RV-PA coupling. Option D, decreased LA function. And E, increased plasma volume.
Okay, time starts now.
इंक्रीज एलए फिलिंग प्रेशर होता है, ठीक है. डिक्रीज एलए फंक्शन भी होता है, इंक्रीज प्लाज्मा वॉल्यूम भी होता है, ठीक है, कंपनसेटरी तौर पे. तो ये ए डी ई तो आउट हो गए, बी और सी रहते. डिक्रीज डायस्टोलिक रिजर्व तो इंक्रीज आरवी एंड पीए कपलिंग. ये क्या है?
नहीं होगा. नहीं है.
नहीं, डायस्टोलिक रिजर्व तो बढ़
नहीं रिजर्व बढ़ेगा.
डिक्रीज डायस्टोलिक रिजर्व
नहीं
ए ठीक है, बी ठीक है, ई ठीक है और डी भी ठीक है. हाँ, तो फिर सी बनता है इसका आंसर.
40 seconds left.
बी और सी में चूज कर लें. ए डी तो दे आर. तो फिर सी में फाइनल कर दूं. फिर
30 seconds left.
increase LV filling pressures, ठीक है. RV और PA coupling.
Final 20 seconds remaining for you.
RV.
Okay, 10 seconds left for you. A.F.I.C lines. 8 seconds.
We're going with
5
option
seconds.
C.
Okay,
Option
stop
C.
timer. Stop timer on the lock option C. Right answer. Congratulations, A.F.I.C lines. So with this, we will move towards question number 10. This is the final question. Okay. Yes, Prince, that is
This is going to decide. This question is decisive.
Yes,
Question
sir,
number
take
10.
it. Yes. Go
Question
ahead,
number
please.
10. Patient started on medicines and improves clinically regarding non-pharmacological therapies. Which one of the following is true? Sodium restriction to less than 2 grams per day may be effective. Option B, excessive fluid volume intake should be avoided but balanced with respect to renal function. Option C, if sodium and fluid restriction together with diuretic use result in decreased GFR, optimal volume status may be characterized by some amount of permissive peripheral edema. Option D, exercise training in patients with heart failure with preserved ejection fraction may improve exercise tolerance, although the effects on indices of the diastolic function have been variable. And option E, all of the above.
Okay, F.I.C lines, your time starts now.
A is fine. B, excessive fluid volume intake should be avoided, but balance respect to renal function. हाँ, बात ठीक है ये. If sodium if sodium and fluid restriction together with diuretic use, एक second, सारी options एक बार देख लेते हैं. If sodium and fluid restriction together with diuretic use results in decreased GFR, optimal volume status may be characterized by some amount of permissive peripheral. हाँ, ये बात बिल्कुल ठीक है. Permissive peripheral edema allowed होता है. Exercise training in patients with HFpEF may improve exercise tolerance, although the effects of indices हाँ diastolic function. So
Okay, 50 seconds left for you, F.I.C.
बस मैं
Lines.
we are going with option E, all of the above.
Okay, are you sure you still have 40 seconds left?
Yes, please lock the option.
Are you sure? Once again, this is the final. Okay, we'll lock option E. Please, Hamza, stop the timer and lock option E. Right answer. Congratulations. Very well done, A.F.I.C Loins. Very good. I mean, a great match. Both semifinals were really great with, each scored almost equal. So don't be disheartened, P.I.M.S Leopards. You have played very well. With this Hamza, I would like to get opinion and comments
यार वो उन्होंने आखिरी चारों सही आंसर किया.
of Professor Firoz Mehman. Is he with us?
Sir, Professor Feroz Mehman has just left.
Okay, so with this, I would like to
So
move.
we have with us the coach of A.F.I.C Lions, Brigadier Asif Nadeem Saab.
Okay, we'll have a little opinion about. Okay, we'll move towards Asim Nadeem Saab. Please, Asim Nadeem Saab, please give us your comments about the game of the round.
It was an excellent match, and P.I.M.S team they played very well. And it was last ball 6. Mia Dad ka chakka yaad aa gaya. So thank you very much, and thank you again, Wilsons and all the participants, and Sir Ishaq and Brigadier Abdul Hamid Siddiqui and everyone. So thank you very much, and heartiest congratulations to our. Thank you, sir.
Thank you very much from you. With this, I would move finally towards Professor Ishaq Saab, just to give his valuable comments for this game.
Thank you, Asher. It was very exciting and very interesting match today. Both the questions were slightly above standard, but I think they were equal match, and both the teams played very well. One or two questions were quite tough as well, at least to me. But I think that tells us about the importance of physiology and basic sciences that our trainees and fellows need to appreciate and understand, which is something neglected. So I was fearing that we'll heading towards a draw, but thanks to A.F.I.C, वो क्या कह रहे हैं, ब्रिगेडियर नदीम के छक्का मार दिया तो फैसला हो गया, वरना हमारे लिए मुश्किल हो जाता है फिर ड्रा हो जाए तो फिर we have to have a second session and this and that.
Yes.
So excellent. It was my player that I have attended all the matches except one. when I was traveling, and I really enjoyed it, learned a lot, and I think it's a very, very healthy uh, exercise for each Mrs. Wilson needs to be complimented and their efforts appreciated. And I also like to thank my distinguished colleagues, Professor Firoz, Kazmi Saab, Brigadier Ahmed, and Brigadier Nadeem. I think it's a very good platform to meet friends as well and learn from each other. So well done, A.F.I.C. Congratulations. And this was today was your day, and you have the right to celebrate. Thank you very much, everybody. I would like to take your permission.
Thank you very much, Professor Ishaq Sir. You are
My breakfast time is here in England, right? Weekend breakfast is usually late, so uh, family is waiting for me to join for the breakfast.
Thank you very much, sir.
Allah Hafiz, and see you in the final then. Allah Hafiz.
Thank you very much, sir. Your presence is always, is appreciated from our side. Thank you very much. With this, I would like to move towards Professor Fawad Kazmi just to give his final comments as well, if he is with us.
Yeah, I think I've already given, I think, congratulations to A.F.I.C. It's been their second, they're moving to final, and if they win the final, it will be their successive win in two contests. I mean, they won the Fit Jeopardy also. I think it was, as Professor Isaaq's questions were very good this time, and very good standard. Again, I think we are nearing the end of this league, and we hope this will continue and even improve further and become even better. Thank you very much, Wilson, for your support and all the colleagues. And thank you, Asher, for conducting it so well. Thank you very much.
Thank you very much, Professor Fawad Kazmi. Okay, just a short comment from Professor Brigadier Abdul Hamid Siddiqui Saab. Sir, please.
Yeah, I think full marks and congratulations to A.F.I.C team and Gappa for the P.I.M.S Leopard and very good moderation from Dr. Saab Asher Saab.
Thank you very much, sir. I'm really apologize for today because we have internet disconnection couple of times. Anyhow, with this, I think again, congratulations to A.F.I.C Lions to reach the final. Good luck for final as well. And P.I.M.S Leopards, you played very well. It was just a one question, so don't be disheartened. You might be in the finals next time. So good luck both teams. And with this, I would like to give mic back to Hamza. Hamza, please, if you have to announce anything, you can do it now.
Yes, sir.
Thank
This
you.
was the last match of season 1, and hopefully we have proceeded towards the final of Cardiff Super League season 1. And I'm greatly thankful to all the senior faculty members, especially Professor Muhammad Isaaq, Professor Firoz Mehman, Professor Khawar Kazmi, Professor Fawad Farooq, and Professor Jalaluddin Achakzai, Professor Fateh Ali Tubu. They were the governing council members of this Cardiff Super League first season. And especially to the current president of Pakistan Cardiac Society, Professor Javed Akbar Sayal, and Vice President Professor Dr. Ambar Ashraf. And without their support, this league was not going to happen. And hopefully, this final will be played in the physically in Cardiocon on 18th November, and we will be sharing the time slot, and we will be traveling physically towards Sakhar, inshallah, for the final on 18th November. And last but not the least, I'm equally thankful to moderator of the program, Dr. Ashraf Bilal and Dr. Hamza Gori, for moderating and for helping us and to conduct this season 1 of Cardiac Super League. And with this, congratulations to A.F.I.C and commiseration to P.I.M.S Leopard. And news from the center is that final will be played between two teams, Jinnah Eagles and A.F.I.C Lions. And with this, I would like to sign off. Thank you very much, everyone, and take care, and Allah Hafiz.